We have over 110 chapters in 26 countries, 3,000 startups, 1,000 attendees that attend the Optimize conference, and 40,000 global subscribers. We've seen a shift in the last few years in terms of how we are approaching and supporting innovation with the older adult population. In the past, it would have been about how we support older adults with more medical-based needs and about designing systems for just the older population and much more institutional. With the growth of Aging 2.0, we've really been about opportunity and having various sectors of health, wellness, and lifestyle work together to bring about greater function for the older adult. And older adult just doesn't necessarily mean the person, it's their community. It could be for their caregivers, could be for their neighbors, it could be for their home, and looking at aging in the community and aging in place, whatever that place may be. So it may be in your home, it could be in an older age community. And really, it's about driving profit and nonprofit partnerships. So as I mentioned, it's a global network of innovation communities, and 55% of all of the startups are female founded. So if you are interested in getting involved with Aging 2.0, we do encourage you to sign up with Aging 2.0 and look for your local chapter. And then you'll be added onto email lists, and you'll be sent information over various workshops and a lot of these monthly virtual events. So our next event will be coming up in December. And as with everything going on in the world right now, we are going to be having virtual events. What we would love is for people to come and share a COVID-related item or story. What we'd love to do is find a way to capture all of this into a time capsule. And then again, in about 5 years, as a community, we'll share what happened in 2020. And also, please stay tuned to some of our virtual events that will be coming in January and February in 2021. This is our chapter team. So you've met Aparna. Bethany is a co-ambassador, Anne Jones, and myself, Catherine Wise. I'm one of the co-ambassadors. And with that, I will give it back to Aparna. Thank you.
Hi, everyone. Again, welcome again. And I would like to start today's session by introducing Dr. Nathan Estrada. Dr. Nathan Estrada is the VP of Clinical at Nymbl Sciences, which is doing some fascinating and groundbreaking work on fall detection and fall prevention. And with that, I will actually have Nathan share a fantastic story that he shared with me just a few minutes ago. So Nathan, you're on. Go ahead.
Step one, unmute again. Thank you so much, Aparna. So Dr. Nathan Estrada, I come from an interesting background. Started off in sports medicine as one of the first 50 board certified sports PTs in the nation. Exciting work to do, very fulfilling, and not one that's coherent with the family. So came back to Colorado, worked at Children's Hospital Sports Medicine for about 6 years. Loved every minute of it until my kids got to school age, and then realized it was either help other people's kids or help be a father to my own. And then really kind of went to working with older adults as a reprieve, quite honestly, and fell in love with bringing people back to life, with being able to empower people to do the things that they had thought they had lost. And that really kind of moved me to start working on clinical training and expertise for therapists and clinical teams in senior living, became a program manager and a clinical educator, and then really started hopping into population health after seeing that our system's not designed to really meet the needs of an older adult from their perspective. It's designed to meet the older adult from our perspective. And so seeing if we can impact that in a positive way. So that's how I found myself to be the VP of clinical. My passion for fall prevention actually comes from my grandfather, who I was his medical power of attorney, and he fell and had a subdural bleed. And that was really what ended his, not only his independence, but his quality of life and his ability to care for himself. We lost him last year, and it was truly because of the fall. And so I'm on a mission to really show that two things. Number one, that aging is not less. Older adults are not other people. They are not. They're not some subsegment to be ignored. They're us. They're just older. And number two, that no one deserves to get the call that their loved one fell. And if we're truly going to impact that, we have to work with older adults directly to do that. Anyway, so that's my not so brief introduction. I apologize, Aparna.
Oh no, that was fascinating. Thank you for sharing that.
So, do you mind if I get right into it then?
Yeah, absolutely. Go ahead.
Okay, let me. I'm going to make some relative assumptions of this group. Number one, I want to talk about where we've been briefly, but I don't want to focus on that. I do want to only do it on the learnings of where we've been so that we can move on to where we can go. Because this is, as I say below here, moving beyond throw rugs in classes. Because that's where most people think about things in this space. So first off, we've all seen the statistic that 1 in 4 older adults fall each year. Sometimes when you circle 1 in 4, it feels a little bit different than actually saying 1 in 4. It's expensive, and from the 800,000 hospitalizations and 27,000 deaths, 1 in 6 falls is an ED visit. 1 in 19 is an orthopedic surgery, and about 95% of all orthopedic hip fractures are fall related. So when you look at that, the primary driver of this cost is actually fall fracture care. When we look at it, it's about a $50 PMPM on a Medicare plan. Said another way, every time someone falls, it's about a $3,900 value in the United States. So the hard part about it is it's worse than a quarter of people fall. It's a third. A quarter like to talk about it. A third actually have it occur. If you are a faller, on average, you fall twice per year. And half of those who return to the hospital for a hip fracture within 6 months of having that fall as well. Some skilled nursing, we know skilled nursing has a lot of falls. I don't want to focus here. They have enough PR issues at the moment, and that are really not fair. But a lot of it has to do with cognitive ability and physical ability meeting in a bad way here. But this is why there's so much focus, because of the density of falls in skilled nursing, and specifically the frequency as well. So I'm going to start off today by saying, what part of the client experience are you impacting? And it's an interesting question, because most of us think we're impacting at a different level here. And so aging in place all the way to post-discharge, what are those intervenable points that we have? And then I'm going to ask you, does your impact match the right research base? And that's a question we're going to come back to at the very end. And I really would like to have a dynamic discussion about that. But for the most part in the world, we look at when someone falls, it's the alarm, and then we intervene, right? It's the medical model. A lot of times we confuse prevention with mitigation. Mitigation is trying to make someone fall 3 times instead of 4. Prevention is trying to let them not fall at all in this first place. And so let's make sure we keep that language clean. So we're going to go over a quick review of the last 15 years of fall prevention, a little bit of what we could be doing, really focus on why balance is a reflex and why that matters, and then some implications for the team. So this is the medical model. I hope most of us have seen this actually exact slide, because what it shows is, as a clinician, how I look at falls. I look at all these environmental, biological, demographic, and behavioral aspects of a fall, because each one of these are things that, when I'm creating a community-based program, historically that I would look to intervene on. So it's easy. You start making little check boxes of hypotension. Have we talked about blood pressure medications? Weakness. Have we done a strength test? Have we looked at vision? And the reason why this is really helpful for clinicians is because it creates a checklist of my to-dos so that I fulfilled my duty. The hard part about this has very little correlation with how an older adult interacts with falls and the things that they can do. And then when we look at it from a frequency perspective, there's a fairly large misconception that most falls are medically related. Most falls are preventable, which means that they're truly balance related, environment related, or some kind of easily preventable medication or symptomology thing. True like drop attacks and different things like that, that we tend to think of as those catastrophic hospital falls, are fairly rare. So when we say things like most falls are preventable, the reason why most falls are preventable is because they have to do with ability far more than a sniper rifle taking someone out. We're not playing soccer and people are taking dives. These are normal occurrences. And by the way, all of us stumble. The difference is some of us catch ourselves and some of us don't. So about 15 years ago, we declared falls an epidemic. And that epidemic was for good reason. And so we made a medical model of falls. So we're going to screen for it, we're going to assess risk, and we're going to intervene. And the whole reason why that started 15 years ago is because there was no best practice. It was the Wild West. It was guru-based medicine. So there's 5 levels of evidence, all the way from a randomized clinical control trial to Nathan's opinion. Nathan's opinion is called guru-based medicine. And there was, for a long time, we were really based too far on clinical experts who just kind of would propound their expertise to people, and then other people would follow. And so no best practice was an issue. Only 30% of doctors talked about fall risk in an annual review with an older adult. And so we said, we're not talking about it enough. And then, of course, we weren't credentialing people as evidence-based. There was all kinds of really exciting interventions in the market, and we wanted people to go, specifically if the government was going to pay for it, to the most efficacious program that had the best evidence. Now, we're going to talk about why this whole process might not have served us very well. But before we do that, I want to just quickly orient people to the clinical model because it helps explain the results. When someone falls, we put them in 3 major categories of low risk, moderate risk, and severe risk. And I don't want anyone to read anything on this screen. If you need this, I'll send you the whole protocol. But the reason why I bring this up is because this algorithm was designed to meet the needs of the provider to be fully compliant with all the things that we needed to do to be reimbursed and to check all the boxes. And it's really helpful. So it reminds me that, okay, does this person have a vitamin D deficiency? Maybe I should discuss that. Here's the real problem is when we make a recommendation, how often does that recommendation get followed through? Well, I'll let you know. When you provide the recommendation for low risk individuals, only 8% of people followed through. And that's a problem, right? Because we were giving them the best knowledge that we had, right? We had checked all the boxes and we told them to go to a community strength and balance class. And by the way, that 8% has not changed in 20 years, okay? The next thing is if someone is a moderate risk, not all of them are driving at that point in time, so they had to ride the bus to a community-based program, and only 5% found themselves there. And those community-based programs were not fall prevention programs. That was any wellness offering outside of the home. If you look specifically at fall prevention classes, only 1 in 400 older adults found themselves attending one. But we weren't too concerned at this point in time because you have so many people that haven't fallen yet. In other words, low and moderate are your non-fallers or your one fall without injury. They're not expensive yet. And so then we get in the high risk category, and that's when you really trigger a lot of the clinical model of, hey, we're going to go through all the algorithms. We're going to look at foot health, vision, home safety, PT and OT, and all those cognitive issues. And then here's the real reality of that is every time we had that conversation with an older adult of how broken they were, because no one did anything post that, what we really were doing was introducing fear. And the introduction of fear became very pervasive. So an older adult that's high risk, and if they went to the hospital for something, their primary care told them how risky it was when they saw them in their annual visit. The hospital put a band on their wrist and said, high fall risk. And then when they lay down in bed, there's a little sign on the ceiling that says, call before you fall. And there's an alarm because I'm so unsafe. If I move, I could fall any minute. And so all that fear and all that psychology there didn't serve us well because no one acts appropriately when they're in a fight or flight state. We've seen that acutely with COVID, haven't we? When people get in fight or flight, they have really unique behaviors and almost none of it's productive, okay? And so from that fear model, we want to then just move, okay, what impacts an outcome for falls? And this is not a rhetorical question. We're actually going to talk about this later. Do we actually impact the outcome by identifying it more frequently, by the clinical evaluation, by the recommendations we make, or by what the patient does? And I think inherently we all kind of know it's what the patient does that actually results in the real outcomes when it comes to this, because all the recommendations in the world that are not completed have no value. So let's talk about how we performed on this. So we have some great morbidity studies, and I don't mean great from positive perspective, but we all know that deaths from falls are increasing. But the question is by how much? Well, JAMA found that if you're over 75 years of age, the rate of mortality has doubled. In other words, older adults today are twice as likely to die from a fall today per capita as they were in the year 2000. So what changed there? And the only real systemic change was making falls a disease. The next aspect of it is, okay, we have this clinical best practice. We're going to throw all the bullet points at an organization, and the New England Journal of Medicine recently published this one. And it was a multifactorial intervention. In other words, all the bullet points administered by specialty nurses who were specially trained in fall prevention methodologies did not have a significant impact on falls. And that was disheartening for the whole market, because almost all of us as providers want to think that all the work that we've been doing has a measurable impact. But when older adults don't follow through with the recommendations, we have a significant mismatch. And as we currently look at it, 92% of all older adults currently do nothing for balance training, regardless of their risk recommendation. So it's an unintervention problem. So let's talk about the screens and safety assessments first. Screens are designed to find people who might fall and people who will fall, not people who are going to fall. And that's a hard thing for people to hear, because when people fail a screen, they don't receive it as, hey, this simply means we need more information. They perceive it as a brokenness, that I have a future impending fall. Like there's this doom and gloom associated with that. And so because they're designed for that, they actually create false hope. In other words, if you pass it, you're not going to fall. That's not true either, right? False fear. If you fail it, you are going to fall. And then you have home safety assessments, which are really challenging to scale. And we're going to talk about how that may not be in everyone's best interest anyway, because who does that adaptation? And does sterilizing someone's world make them safer, or does it make the world more dangerous for them to navigate? And so I like to use the quicksand analogy of, a lot of times we put older adults in front of a quicksand sign and it says, fall ahead. They can see that there's quicksand there. And we just told them, you failed the test, walk forward. That's how they feel. If they pass the test, they get to turn around. There's no danger the opposite way. And that's why the psychology of screening can be a challenge. So why does fear matter so much? The number one predictor of a future fall is a past fall. The number two predictor of a future fall is fear of falling. And because it's so pervasive, I mean, look at this. If someone's fallen and they're fearful, their risk of a future fall jumps from 37% to 56%. Now, if you have someone who has the same physical ability, they're 5 times more likely to go to skilled nursing when fear is present. So every time we told someone that they were broken, that they were high risk, and we gave them something they weren't willing to do, we actually fed this cycle. And the real problem is because 9 out of 10 adults will not do the recommendations as they're given. So exercise and balance programs, there's a lot of really good ones, and they have a high variety of outcomes. Some of them work on fear of falling. Some work on physical balance skills. Some, like the Otago program, are amazing at growing muscle mass. And one of the issues that we have is, as a community provider, do I know enough about what's available to match the need of my patient to their actual need? Here's a great example. If I send a weak older adult to Matter of Balance, am I helping them? Well, Matter of Balance, their outcome is 98% report they have increased ability to talk about fear of falling. If it's a non-fearful weak patient, that had no impact on them. In other words, I sent them an intervention that actually was mismatched. And so we need to pay attention to that, because here's what happens. Is those community-based programs are so targeted on a specific aspect of fall risk that we end up missing the overarching need of a lot of people. And so it looks like this. You have John, who's feeling pretty good. He sees his doctor, who analyzes his fall risk, tells him, hey, these are the things that you could change. John now starts to change his shoe wear because he had these these slippers and he could trip on them. But not only does he change his shoe wear, but he actually then starts to think about what are the things I shouldn't be doing because I'm actually at risk. So maybe takes the escalator instead of the stairs. Whenever that happens, people's activity go down. They might fall in love with golf, watching TV. We actually see deconditioning. And that's when time really is not in our favor because as people's activity levels go down because we told them to do less, we literally told an entire population to do less until they got intervention. And since they didn't get intervention, they said, well, then I better be careful. And a lot of people even homebounded themselves as a result. So then they go in the environment, and the environment's not normal for them. They're used to having this sterile world where they removed all their throw rugs. They actually do fall, and then when they get to the hospital, we start the cycle over again. But instead of changing my shoes next time, maybe it's I don't leave my house. Maybe it's I stop using my basement. Maybe it's I need to move. And so when you look at those psychological triggers that happen in that cycle, it's very challenging. And then you get into the current interventions, which are, I call it the fall prevention NIMBY. And so NIMBY is not in my backyard for those who aren't familiar. Well-intentioned, and I want to be very clear, these are what we've done to meet the regulations. And the providers in these environments are doing the best they can. And no one has malintent on any of these things, but there are some natural consequences. In a hospital, when we put a bed alarm on someone and we don't allow them to move, it takes 4 days of strength training to recover for every day of bed rest in a hospital. It's so frequent, we have a name for it. It's called deconditioning syndrome. In fact, in a hospital, there's no trip hazards, so there's special socks, right? And we're checking on people every few hours. And so on the patient side, what they really experience is a significant weakness event. And they haven't slept well in days. At least I don't sleep well in the hospital. And so you end up with a weakened and confused client upon discharge, but they didn't fall. Now, we celebrate that they didn't fall, but we also have to realize that there was a consequence or a payment made on the patient side for that. The next part is they might go to a rehab, up with assist only. They do intensive rehab. We remove all the dangers, and then we discharge them to home. By the end of their rehab stay, a lot of times what we see is their routine is so disrupted into this routine of meeting our needs as clinicians to come in there and help them. And they've been socially isolated for a little while. So they're a little bit more scared and alone. And of course, most of them are kind of exhausted. So they go home, but we have the safety net of home health. We screen them again, tell them they're high risk. We do some medication management. We walk them to the mailbox because Medicare says if they can walk to the mailbox, then they're no longer homebound. And we discharge them with a piece of paper or some guidance. So you can imagine if someone spends 4 days in the hospital and 8 days in rehab, they're actually still not back to the strength they had before they even got to the hospital at all. And so it's a tough cycle. People don't graduate the system healthier. They graduate the system at the closest to baseline as we could get them. They're not above baseline usually. And this all comes back to the model, and what I was saying earlier is no one does what they should. Even if you give someone a PT home exercise program, do you know only 25% of older adults complete it? And when you're looking at that 25% completion rate, it gets back to that efficacy of the recommendation doesn't change the outcome. It's what the patient does. And a lot of times we spend so much time telling people what they should do. And that's problematic because there are some things that don't work at a population level that we tell people to do. And it's not that they're bad, it's just they don't work for population health. The hospital-based classes don't work. And the reason why it's the 1 in 400 older adults are capable of getting there. So they never meet a population level. General exercise has never been shown to improve balance. And so there's a specificity problem. You can't send someone to silver sneakers and hope that their balance improves. Video surveillance is not something older adults love, and it's expensive. Soft floors has not been shown to decrease fracture risk. Hip protectors and airbags, I have very specific thoughts on those from an intent or an honor in treating older adults as other people. Walking more does not decrease fall risk. Linear programs, in other words, one size fits all, doesn't scale because there's a huge variation of acuity level, of motivation, of life experience. And for that same reason, most balance programs that are the same for everyone are very poorly tolerated. Of course, programs that people don't do don't matter. And then fall detection at a population level is getting close. And what I mean by that is the center-based packages are getting cheap enough and non-invasive enough to where we're starting to achieve the threshold of which older adults actually like them. Because if older adults like them, they will use them, and it gets back to that prior model. So let's talk about what older adults want, right? Once again, older adults are us, not other people. So you have to always start with what the things that you like. And from that perspective, we're going to move very quickly to what is balance, because then it's going to force us to go what older adults want after that. So balance is a reflex. You cannot think about regaining your balance. So if you stumble, your brain doesn't have enough time for you to go, well, Nathan said in balance class to do this if I fall. No, you already fell. And so that reflex lives in the cerebellum. The cerebellum is that little cauliflower on the back of the brain. It's the quarterback of the brain. And it really focuses our abilities when we're on unconscious movement. So you don't have to think about putting your left foot in front of your right because you have a cerebellum when you walk. Now, if you thought about your walking, it changes your walking pattern dramatically because that becomes executive function movement. The hard part about it is a lot of balance training today focuses on executive function balance, thinking about what your ankles, knees, and hips are doing. And because of that, it doesn't directly interact with what happens in someone's everyday life when they stumble, when they're distracted, which is part of the problem that we have on balance training programs and why they don't prevent falls as frequently as we would hope, because of that lack of carryover from executive function to cerebellar. So you have to train balance like one. And we're just like anyone, the brain's great at cheating. So if you give the brain the ability to think about it, it likes to, and it doesn't force the cerebellum to do it. So to truly work on the reflex of balance, research indicates that you have to have a dual task balance. And what that means is you have to have a cognitive challenge and a physical challenge together, and the body has to focus attentional value to the cognitive challenge, forcing the cerebellum to go, fine, I'll take care of the movement. And so if you're talking about helping balance in a distracted world, you have to train the body in a distracted state. Now, the research validation, this is a force plot on the right-hand side. Basically what this means is a traditional balance class is on the left of that little line. On the right of that line is a dual task balance class, or balance experience, I should say. And those little blue bars are confidence intervals of which one had a stronger outcome and to what degree that strength was. And so you can see that there's a universal favoring of dual task to impact these variables or these outcome measures for everything but short-term memory, which makes sense. If you're giving someone so much information, they can't retain it from a memory perspective, because that would be executive function again. Now, if someone has a history of falls, dual task balance training improves their balance, helps their ability to dual task, which is crucial, cognition and memory. But just as important, if someone doesn't have a history of falls, it reduces fear of falling, improves balance, reaction time, and cognition. So since those are the validated outcomes, those are the things that we want. We want people to have better reaction time because that's the reflex. And when you react in time, you step instead of fall. So balance is made up of three main systems. I won't go deep into this other than to say that your inner ear, your vision, and your joint sensation tell your body you're falling or you're not. Older adults, as their joint health declines, as their inner ear sensitivity declines, as their vision declines, have a naturally reduced balance sensation. And in fact, sometimes it can be so reduced that we rely fully on vision and ignore the other senses. And when you ignore the other senses, you have to see yourself falling. And that's a real problem, because if you're falling forward, you can see it, because, for instance, if I'm looking at a tree in front of me, it gets bigger. I know that it's getting closer. But if you're falling sideways, you see stuff shift sideways as well, but to a different degree. In other words, I can see shifts left to right really quickly with my vision. I can't tell that that tree is slightly larger very well. So falling forward and backwards is really a challenge when it comes to vision. And we tend to put blinders on, which are the sides of eyeglasses. Don't let me see my peripheral vision, which has the highest ability to see change in situation or change in kind of stature. The next problem they have is the inner ear only works if the head is upright. In other words, when the head is turned down looking at your feet, and we can talk about why older adults do that, the balance sensation doesn't know you're falling backwards until you've fallen all the way backwards, because you have to pass neutral. So if your head's down, you don't know you're falling until you're all the way here. And then my brain knows I fell backwards. But if it takes that far, I've then lost my window of opportunity to have the alarm so that I can react. And of course, joint sensation becomes less accurate with arthritis and joint collapse. So if we're going to make balance a reflex and we're going to train it like one, then the real question becomes, what is the role of strength and what is the role of the reflex? There's no doubt that strength training improves balance. Strength training reduces falls. The therapeutic dose for strength training is anywhere from 60 to 90 minutes a week. Anywhere from 4 to 8 months is that validated period where you consistently see people falling less. The problem is that is once again something that everyone should do. And that's not frequently what older adults want to do, which is why we see participation in strength-based programs be so low, because it's hard. It's hard to commit that much time to it at a population level. If I asked everyone on this call to do something for 90 minutes this week, you guys would laugh me out of the room, let alone to do it for the next few months. But there's no doubt that deconditioning is an issue, and there is no perfect exercise for balance training, by the way. And specifically, if you can think about what you're doing, it's even worse. So then we talk about the brain, right? You can't just train the brain either, because we know that people with dementia fall more. That makes sense. As cognitive bandwidth gets more narrow, there's less tolerance for distraction. And if it gets narrow enough, we have to make this uncomfortable choice of, do I pay attention to distraction or my mobility? Because I've been focusing on executive function movements for so long that I then have to focus on it. And then people fall. And then when people are distracted is when they tend to fall. And so you look at all those cognitive challenges, and both together has always had a better outcome, which is why physical therapists distract people. Physical therapy is wonderfully productive, and so is OT, because we don't do anything isolated. We do things in functional ways, in distracted positions. But home exercise programs almost always lack that because they're flat. They're a piece of paper, some examples. And so it becomes task or executive based on a home exercise program when it was actually very dual task based in the clinic. So when you talk about the brain and body, a lot of times we tell older adults just to do 150 minutes of moderate intensity exercise per week. By the way, if you poll 100 older adults, only 5 or 6 will know what this means. I could ask you guys, what is moderate intensity? And so because recommendations are maybe ambiguous like that, it tends to be less empowering, and people don't quite know how to interact with that. But we do know that strength and stamina matter. Balance directly matters. How people walk, and of course the reflex. Those are all those 4 kind of basic domains. And so we need to be introducing all those domains, not just a single one. I want to point out a great case study, the Dutch. The Dutch don't tell people they're broken. They don't tell people to do less, and they don't remove throw rugs. They don't add grab bars everywhere. They send older adults through dangerous obstacle courses. And what I mean by dangerous is that's the perception people see that. And there might be 20 stations. And the first time an older adult sees it, they go, ooh, man, maybe I'm not healthy enough for this. And then they go through it and they go, hey, there's only 5 or 6 of those that I actually struggled with. The rest of them I was fine. They come back a week later and they know those 5 or 6 things that they struggled with the first time. And they go, you know what? I wonder if I can get better at them. And then suddenly it becomes, they go for a few weeks. And at week 4, there's always 1 or 2 of the factors that are still dangerous or that they feel are dangerous. Here's what that does. Is think about all the different environmental cues that we look for danger in the world when you're told how dangerous it is, and how often we limit our access to them or through them to participate in life. If I think that a curb is dangerous, I suddenly stop participating in restaurants. I don't go to the store. I don't do these things because there's a danger in the way and I don't want to risk it. If you can help people understand their true ability, well, then they can only limit their life by true dangers. And then it also empowers them directionality to address it. So I love the Dutch program. In fact, we're doing that in Colorado now. It's a pilot. So let's get back to this acuity scale. So what part of the acuity level? So I asked the first time is what part of the client experience are you intervening on? So now I'm going to bring it back to acuity. So we have Olympic agers. We have a lot of older adults that are much healthier than I am. They're running marathons. God bless them. I love it. I get these texts from our users that said, I just got done running 5 miles. I did my 10 minutes of Nymbl. It's like, thank you, right? And then you have people on the other side that are chair bound, right? I mean, and they're falling every day. And so there's this continuum. Well, we talked about this non-intervention curve. Well, only 8% will leave their home, and they're almost always the well. In other words, the people that attend a community-based program are usually a mismatch of people who needed to be there because they overcame all the barriers to get there. And then on the other side, you have about the 8 to 11% annually that have some kind of fracture-related clinical claim or care. And those people are really expensive, and they're on the clinical side of something. And then you have this 80% in the middle that do nothing. And so I'm postulating, or I'm asking us, can we focus on the 80%? In other words, true prevention happens in the middle. The needs on the left are already being met. They're already doing everything they should. And the needs on the right need to be in the clinical realm. Can we meet the people in the middle? And once again, before COVID happened, only 1 in 400 older adults even found themselves in a bounce class anyway. So then here's the real crux of the conversation I want to get to today, which is, does your impact match the right research base? Here's how research works, is we study a problem. We then move through, and there's some great ideas, right? And then there's some external validity of, hey, this had worked with a few people. And then we move it to the clinical setting to make it valid, and we sterilize it. We remove everything down to its foundational levels, and we take out any confounders so that there's minimal variety. Here's the problem, is when we did the evidence-based movement, we didn't say all the things that were generalizable. We actually focused on all the things that were clinically valid. And when something is clinically valid, it's all the things you should do. It was best practice. It was gold standard. It was Otago. It was all these great programs that no one wanted to do. And so when you look at that, if we're going to get to a population health perspective, we have to get out of the clinical trial 4,000 and have to go, how do we personalize this program to this individual? Because when you personalize it, we get to the want to. And if you can find the right balance of the should do and the want do, you get the will do. And that's the real magic of population health in the real world chaos that we live in today. So if we're going to do that, we can no longer rely on human-based interventions at a population level. So here's what we've tried. We've tried train the trainer. Let's get enough community-based classes. Let's put them out there. And let's let them come. If you build it, they will come. And that's just not the reality when people have fear involved. And so we have to leverage technology to partner with older adults, and we need the data to personalize it. And we stop asking for my data to help me bill and start asking for the data we need to design the program for the older adult that they will do instead. The next aspect of it is we have to engage clients and give them what they want, and we have to personalize it. We have to take that data, we have to create and personalize something that they, based on their goals first, to meet our goals far second. And here's a great example of that. When I used to start a physical therapy client, I would always go, do you want to exercise? Half of the older adults would say, thank you for asking, I don't. Say, great, I'm a physical therapist. I offer wellness through mobility and ability. And so you've invited me into your home, and you've said that a lot of things I might ask you to do, you're not interested in. Well, would you like me to take out the trash instead? What is it that I can bless you with today? And they go, well, no, I have a goal. It's like, great, what is your goal? Well, I want to make the family reunion. Great, that's data of what motivates them. What stops you from making the family reunion? I'm scared to walk on grass. I have the exact functional movement she needs. As a result of that, I can then design a program that goes, hey, here's what's stopping you from being confident and competent in that. And we don't need humans to do that. We just have to have the honor and integrity to ask older adults what their problems are and what's stopping them from participating. You can do that with tech. You can do that by personalizing things. And then moving from episodes to permanence. Getting out of the habit of doing what I need to do for my daily workflow today is the goal. No, the goal is to empower someone to a permanent outcome. We need to focus on what lasts, and what lasts is what people will do. So I'm asking us to get away from clinical rigor here. I'm asking us to move away from best practice and instead start with what are you willing to do? And I'll just give you what you're willing to do and grow from there. Because if I can grow from what you're willing to do tomorrow will always be more than what you're willing to do today. And if I have the technology to collect that data as you go, well, then suddenly I can actually empower a program that personalizes and custom tailors to you permanently. So the implications for us are this, and then I'm going to leave plenty of room for questions, is we have to take brain and body training as table stakes. This is not, hey, I think we might be able to add some cognitive challenges. If you're not having cognitive challenges, or at least complex movements, like a good example is someone standing with feet together and trying to put one arm forward and one arm back. I won't make you do it on video because I'll be the only one capable of doing it. It's that cognitive distraction of what I'm doing with my hands is enough to allow what I'm doing with my feet to be a reflex. The same reason why we want people to walk and talk. We want people when they're walking to see how many blue colors do I see? How many birds? What type is that? And be cognitively engaged in their mobility because that's what impacts balance. And we have to partner with people on what their goals are first. We have to empower them with where they can and want to start. And we have to use a village approach. And here's what I mean by that, is we got to get out of each other's way. We can't continue to be, well, I'm nimble and I want to help everybody. No, I help a certain subset of the population. Those who are doing nothing in their home, who have the ability to stand and have a smart device can do my program. You know what I need? I need partners that manage polypharmacy. I need partners that help with strength training. I need partners that help on the clinical side and the wellness side. And we got to stop acting like we have a program, because if we have one balance program, you have none. And so we have to stop competing with each other and address the needs where we can in a much more cohesive way. And we got to graduate people to more progressive things with honor and integrity and stop being so possessive of it. So I'm asking us to stop rebranding risk avoidance. Mitigation is not prevention. If any of us celebrate John falling 3 times instead of 4, I'm going to call you out as saying you have the wrong priority. You're simply trying to make a bad problem less bad. We need to truly move back to prevention, and let's not confuse the two. Let's stop focusing on the people that already have their needs met. We do not need another community-based class, right? We have enough of them. They're good. They work. And can we please match a client to their own goals to make sure that whatever we give them actually have real impact and meets a need? So today's fall can be tomorrow's catastrophic fall if we let it. We can't sterilize the world. We can't just remove danger. We have to have people participating in it. And we need to prepare the world prepare the client for the world they live in. So please stop just simply saying if we remove all danger, everyone's going to be healthy. Because the reality of it is people need the ability to tolerate the dangers that happen naturally, or they can't participate in the world at all. There we go. And that's my positive ending there of people standing on one foot. These are some fun people that I met a few years ago. So I will open it up to questions, or I should say, I think Louis is going to open it up, and I'd love to engage the conversation.
Thank you so much. So please, if you have any question, put it in the chat room. So we will go over it one at a time. So the first question is from Aprana. So she's asking that balance training, is there an age where it is recommended for balance training?
Ooh, so that's a good point. So this is a psychology trigger more than a physical trigger, Aparna. In other words, people don't work on a problem until they know it exists. 65-year-olds as a whole, 65 is the new 35, right? Feeling great. In fact, when they go to their doctor, they tell, I'm the best ager you ever saw. It's competition. And usually what triggers a need for balance training is not the fact that their balance wasn't bad to start off with, is they suddenly found a consequence. They saw a loved one fall and they go, ooh, I don't want that. What can I do to make sure that doesn't happen in my life? So the psychological trigger to act from 65 to 70 has far more to do with people's life experience and how close they've been with other people's traumatic incidents of falls than it has to do with their physical ability. Everyone's balance has gotten worse since they were 27 years of age. It's just the reality of it, right? We peak early in life, and balance skills also have directly to do with how much you participate. So if your function has gotten small, your balance has gotten small. And so you can predict people's balance by how much they're doing in their world, more than their actual balance testing. When they get 70 to 75, they feel different. And they're starting to seek their first preventative things of, hey, maybe I should start paying attention to this. 75 to 80, some people have fallen and some people have stumbled and they've had a lot of close calls and now they have some legitimate anxiety. 80 is when people have the trigger and they go, please, I can't fall. I'm going to lose my independence. I will do anything if you just tell me about it. And those are all different personas that you have to treat uniquely. So balance that whole time wasn't good unless they're participating in life. And so this is less about balance impairment and when you should start and more on when will you start and how can we use that psychological trigger and catalyze that moment.
Great.
Thank you. So the second question also from Aparna. She's asking that regarding the Dutch optical cost, how does the insurance view it?
Ooh, insurance companies. Well, first off, it's almost always community-based. It's almost patriotic to not let people sit in fear. And look how capable you are is the thrust of the program. Insurance companies love it because their outcomes are far better than anything in the United States currently from a community-based perspective. Because people leave it empowered, not fearful. Empowered people act. Fearful people don't.
Thank you. So the third question is from me. So I have mentioned that I have a weak leg, left leg due to polio. And I am a creative fisherman. I love fishing a lot. And now I start using my walking stick every time I go fishing there because I'm scared of, is that good or bad? I'm relying more on my walking stick.
That first off, that's a great question because it gets at the crux of a lot of misconceptions. So I'm going to back up slightly from your question and then answer it, Louis. There's obviously a social stigma against assisted devices. No one is aspiring to use a walker, right? When you turn 65 or even 35, you don't look forward in life and go, there's going to become a day where I finally get my walker. Right. And as a result of that lack of aspirational nature of it, sometimes we can villainize assisted devices. So that's the first half of that question. The second half of the question is whether you need one or not has more to do with how you use it. If you use a cane correctly, it's a wonderful tool to help you participate in life more safely. If you rely on a cane for body weight, in other words, you're leaning on the cane, you've now turned to a cane into a fall training device. Because what you're reinforcing is that I can constantly lean on a steady surface. And when you don't have that, you fall. So inappropriate use of the device actually causes falls to increase. Appropriate use of it causes falls to decrease. So I'm going to throw that back to you, Louis, is when you use your walking stick, do you use it as a point of contact, which is as it's designed, or do you use it to bear your body weight? Because if you use it to bear your body weight, then you probably need to train some other strategies.
Good point. I use it more for my body weight because I worry, so I'm leaning it more and more and relying on that.
And so that is the thing that you want to address. You want to get back to the point, if you're going to use a walking stick, to where the walking stick isn't the required body weight support, that it is an adjunct to your current ability. So you have some work to do to build up to that being an appropriate tool in the current moment.
Good point. Thank you. The next question is from Catherine. She said, when it comes to data, not what you count counts. How do we ensure we capture experience versus satisfaction?
Ooh, I think I missed part of that. So I'm going to repeat it back to you. Are you talking about the data that we collect? How do we know that it's valuable? And did you say satisfaction? Was that the last part of that?
So I'm looking at it from the perspective of how we can use tech to help if you are a program planner or if you work in organizing programs. And so obviously from a population health perspective, you truly do need the data to help drive the information. But how do we ensure that we're getting the experience in there? Because I know the one slide you said was not necessary. We can't necessarily look at things from an individual perspective if we want to scale. So then how do we ensure, how are we going to capture experience? And I think you answered a bit of it in your presentation, because I wrote this before you said it, that, you know, you talked about people, how like they wanted to take the garbage out, or like we asked them specific questions, but that's very difficult to scale. So I'm wondering if you had any thoughts about how we ensure we can capture experience, because our number one is always to jump to satisfaction.
Yeah.
And that doesn't really tell us as much as experience. So I'm wondering if you had any thoughts about how we could try to capture experience from a data perspective to help services and programs and technology scale.
Yeah, I love that, because it gets to the crux of it. How do you personalize someone and what information is valuable, right? So I can tell you what we do and how we arrived at that conclusion. What we do is we use the entire study protocol from all the questions. We then have extra questions that would allow us to better understand what you're doing in a normal functional day. Because if I know what you're doing in a normal functional day, and I know your overall risk, I know your polypharmacy, I know your vision history, I know, your diabetic neuropathy, I know all these things about you. Here's what I can do, is I can say, based on the information you've given me, what is your goal? Is your goal to improve your balance as fast as you can, to do it slowly over time, or do you just want to know that you're doing fine? And by allowing them to state a goal and knowing where their risk factors are, it allows me then to know how much attention I have, and I can focus the right interventions that have the highest value first. And here's what I mean by that, is when I collect all that data, I can then say, I can start someone doing something physical that I know they can do. They're doing it in their normal physical day. I don't give people exercise, I give people functional movements. And the reason for that is because in the home, you can't challenge people beyond their ability. That's known as falling, right? And so you give someone a functional movement. All I need to know is what they're doing in their normal day to give them that, and then add a cognitive challenge so they can learn how to do both at the same time. During that, I can collect their cognitive engagement, their physical performance, and then I can constantly ask little micro questions. By the way, did you have pain today, exertion, dizziness? Was it too easy, too hard, physical, cognitive? And by the way, have you fallen since last time? Or I can ask questions like, do you feel like your fear stops you from doing things? By the way, I've been telling you about vision, and we send an email about vision when people say they haven't had it checked, talking about the importance of it. And then I can ask them, did you get your vision checked? And so we can have that model of, I know there's a problem, I can educate about it and empower them with the best ability to interact. And then I can ask whether they acted on that. And that's that data loop that results in value.
Yeah, I think I like that, because it's much more than just looking at the micro data of like, the medication or blood pressure. It's about how does that all relate to function, which ultimately looks at experience, which helps support greater population health. So thank you.
I mean, this is why we launched New Zealand, is we had all the data on I literally know what percentage of New Zealanders have the 13 major risk factors for falls. And then what I can do is really fun, Catherine, is I can then go, okay, what is your program that can help with this? And how can we partner with that program? And how can I shuttle people there? Yeah. And then we're starting to network to interventions. Now I want it because they're going to solve a problem for me that I can't solve. I can't do a medication reconciliation, right? And so when we do that, suddenly we're managing the broader aspect of wellness and getting rid of those barriers to access. People didn't realize how important it was. Mm-hmm. They didn't realize that they're on a blood pressure medication and a mood medication, which automatically makes them high risk,
right?
Regardless of their Olympic abilities. So yeah, the loop is what's crucial. You have to ask, you have to educate and empower, and then you have to assess the efficacy of that, and you have to leave that loop running.
Great, thank you.
Thank you. The next question is from Didi. He says, I'm aware of the need and willing to train my balancing skills, but how I do find good obstacles at home to start training like the Dutch people do.
Ooh, so how do you scale the obstacle courses at home, basically, right? First off, the reason why I love the Dutch program is because it is a supervised community-based program that really addresses some high acuity there. I'm going to take a step back from the Dutch, and I'm going to go a little bit on my clinical side. It's about learned success. The empowerment model only works if you can do things, right? And focusing on the things you can do. And so what I used to do with my clients all the time is say, I don't want you to try to walk a mile. I want, when you walk tomorrow, to walk one house further, just to show you that you can, right? And then the next day, just every day add a house. It's not about getting to a mile. It's about doing something more each day. That's my first aspect of it. The second aspect of it is this. In your own home are plenty of dangers. And like, for instance, a throw rug. There's a huge reflex for healthcare providers to say, throw them out. I got a secret for you. My Aunt Jane likes the throw rug more than she likes her doctor. Okay? And so by simply telling someone to do something they're not willing to do, or feels like it's, pulling some of their independence, I would say is every time you look at the throw rug, make it an obstacle. I'm going to make sure that every time I see that, I'm going to step and I'm going to make it obnoxious. And all those thresholds and all those different things, a stair, I'm going to see how many times I can go up and down, but make those functional movements a normal part of your challenges. It's when you stop doing the challenges is when you lose the ability.
Great, thank you. Hey, everyone, just a quick check. We have a few more questions. Dr. Nathan, are you okay to stay on for another 5 minutes and answer those?
Yeah, I have a partner I should be fine.
Okay.
Thank you. The next question from Don. Would you talk a little bit more about what smart devices you are using and how you use the data?
Ooh, so we use iOS, Android phones, and tablets. So almost every Apple, and we support all the way down to Android 6, if I remember right. Please don't quote me on that. We use the data for multiple ways. Number one, for safety. If someone's moving in a pattern that feels or looks to us to be unsafe, we stop the activity regardless, right? Hey, how you doing? Seems like today maybe you're not feeling as well. We have that check-in mentality. We also use it for exercise progression, because I need to know whether someone's moving. Here's a good example. If you're doing like a small forward step, all that motion going forward, how far your excursion forward is your skill. Your excursion sideways is your instability. So as people are engaging the platform and moving, I can then take that data, and as that instability gets less and their excursion gets more, I know that they're ready for something slightly more challenging. And so it allows me to intelligently progress people's exercises when I'm not clinically looking at them in a safe and reliable way.
Thank you. We have two more questions. The next one is from Laura. What home routines can be effective? Also, how do you view things like grab bars that presume to prevent falls?
Yeah, grab bars are complex. So I'll address that one second. So from a home program perspective, I usually throw that back to the thing, what do you like to do? And let's start there, right? So you have to start off with, if it doesn't result in joy, it doesn't result in longevity. So rather than thinking about what is the best thing you can do, is making a list of the things you actually enjoy doing, and specifically doing this with the client and saying, okay, these are the things that might match, that impact you in a positive way and match their joys to the outcome. We do everything in the home. So all of ours are digitally delivered on a smart device. And so obviously we'd love the world to be doing Nymbl or a program like that. What tends to not work is like the DVDs and sheets of paper, right? They tend to get stored somewhere. They're not that exciting. So yeah, I mean, having home health PT every once in a while, if you're high acuity, can be high. Honestly, doing stuff with friends is probably more beneficial. So if you ask me, should I do 10 minutes of balance training at home that I just have from a sheet of paper, or I go out and have a good time with my friends? Go out with your friends. It'll be much more functionally beneficial for you on the long run. The second part about that was grab bars. Grab bars are an important part of safety in the bathroom in general. We know that it decreases fall risk. Sometimes we introduce them too early. And here's what I mean by that is when we go somewhere and we go, you know what, just in case someday when you are, having bad balance, let's install all this hardware. There's a psychological trigger of brokenness that happens there. And so we have to always match people's real needs and upcoming needs with the adaptations we put in their lives. Because if you adapt someone's life that didn't need it yet, you actually lower their function to that adaptation. So my only caution in grab bars or home modifications in general is we should be a little bit more judicious in how early we implement them. And they should be implemented on predicted near-term needs, not something 7 years from now.
Thank you. So the last questions from Chris. He say, I love the construct you share a few different ways around fear being more of an enabler of harm than a preventer of it. On the other hand, on the other end of the spectrum, how do we know when we ourselves or someone we care may be overly confident in their physical abilities? Any guidance on what to look for and how to assess?
First off, that's the first time someone's asked that, so congratulations. So what you're talking about there is that that cycle between, real understanding, excessive fear, and excessive confidence, right? And it's a self-efficacy problem. So self-efficacy is Bandura's model of perceived confidence to accomplish a task or behavior. And if someone is supremely confident and it doesn't match their real ability, it is incredibly dangerous, right? And I think that's what you're addressing. So here's what I normally do in that situation is when someone feels like they're perfect, we allow them to test themselves and compare them against their peers. So we don't ever tell someone they're high risk, by the way, because we don't believe that that's productive. We just tell them how they compare against other people, their age and gender. So here's what happens is you get the supremely confident person and they go and they score 80th percentile for their age and gender. And they go, well, I thought I was perfect. It's like, well, I mean, there's, 20 out of 100 that are better than you. And they go, well, how do I become that? And so it becomes a trigger to act rather than a trigger of arrogance. And so that's the key there is if you're going to get someone from ambivalence to action, it always comes from better understanding of reality. And so what we do is we just empower people to see reality. And those people that are 90% are the most competitive people you ever met, and they don't stop doing Nymbl till they're 100. And the people that are 40% are just as competitive because they thought they were normal. And no one likes to be less than normal. And so sometimes they go, well, everyone falls a little bit. Well, maybe you have some room to grow. And if you give people room to grow, they usually achieve it.
Good, thank you. That's all the questions.
Thank you. What? Thank you, Dr. Nathan. This was an excellent presentation. We're getting a lot of good reviews on the chat message here as well. But thank you so much for sharing all this information. I'm sure everybody, even people of my age, are now motivated to invest in learning more about balancing, because if that seems like the biggest challenge we will all have, it's probably well worth it to start thinking about it from right now. That was why I asked the question, at what age do you start investing at least in self-management of balance? But thank you again. Thank you to all the audience for all your questions. And we will be posting a recording of this event within the next 7 to 10 business days. And on behalf of Los Gatos Aging 2.0 chapter, I would like to thank Dr. Nymbl Estrada for this. And thank you, team, for making this happen. Thanks for staying up late also and answering all the questions. Bye.
Have a good day.